All right. Hi, everyone. I hope my audio and visual is clear. Please let me know.
Yes, it is.
All right. Thank you so much, ma'am. So, hello, everyone. I'm Dr. Ayush Jan. I'll
Hello,
just
madam. Good evening.
I'll just take a minute to introduce myself. My name is Dr. Ayush Jan. I have cleared my
Oh, you are not
MRCP
madam. Okay, sorry,
exams.
sir. Oh, we
Sorry,
thought
am I
Dr. Neha
interrupting
last
something?
time she gave.
All right. So, yeah, I was introducing myself that my name is Dr. Ayush Jan. I've cleared my MRCP exam, including the PACES, in the last 1 year. And I have completed my medicine residency as well. And today I have been assigned the task to teach you all the approach to element disorders. Before we begin, just take a moment and try to identify these particular patterns. Just take a minute and try to identify these patterns. Are you able to identify which disease are we talking about in these 5 patterns? Take a minute and read and try to understand. So I'll just quickly read it that if you find a patient with symmetrical distal sensory loss with or without weakness, then what comes to your mind? Second thing, if the patient is having a symmetrical sensory loss with distal areflexia, that would mean the angle reflexes are absent and UMN features that the patient might be having some increased tone or something, then what pops to your mind? The third pattern is if the patient is having a symmetrical proximal plus distal weakness with some sensory loss. And the fourth pattern is the patient is having asymmetrical distal weakness without any sensory loss. This means it is a pure motor pattern. And the last one is also a pure motor pattern, which means a symmetrical weakness without sensory loss. So if you are not able to identify even one pattern, don't worry. In the next 30 or 40 minutes, I'll make sure that you identify all the patterns and that you can figure out and localize all the lower motor neuron pathologies. All right, so we'll begin the approach to lower motor neuron. So before we begin, I hope you know the basics of upper and lower motor
Power
neuron.
reflexes, plant of.
Can I please have one volunteer who can come up and answer some of my questions? Can I please have one volunteer?
Yes, sir.
All right. So,
Raghu.
Dr. Raghu, can I call you Dr.
Yes.
Raghu?
Yeah.
All right. So, consider a scenario.
I.
Yeah. So, am I audible?
Yes, sir.
So, consider the scenario that you are entering your neurology session and you greet the examiner, you greet the patient, and you read the command that the patient is having difficulty in walking. Examine the lower limb. So, can you walk me through what all steps will you do?
So I'll inspect the room for any accessories using like wheelchair, any foot orthosis or something like that.
Right?
And general examination is mandate, sir. You're
Carry.
asking me to sequence, right?
I'm asking you, how will you actually go on in a neurology station? That what all steps are
Yeah,
you
I'll
going
look
to
for the
follow?
surroundings, what he's using, like wheelchair or any walking
Understood.
aid or
Next.
any.
What
Next,
next?
I'll examine the lower limbs. In case if it's lower limbs, then is examine for it. In general inspection, look
All
for
right.
wasting, look for involuntary movements, look for
All right.
scars and deformities.
The MINDS protocol, of course.
Yeah,
Then
and then check for regular thing, stone, power reflexes, planters, and clonus. And at
that
the
is
end,
where I want to stop you. So before you go on to do the TPRCS, the tone power
Uh,
reflex coordination. My understanding that I have built in my basis journey was to check for gait before you examine the tone power reflex in a lower limb. That is why I
okay.
specified that I'm giving you a case of lower limb.
Okay, sir.
And I didn't write gait purposely here. So when you enter a session of neurology and you're told to examine the lower limb, ask the patient to walk. Because our job is not to give a diagnosis, but we need to localize the lesion. So when you ask the patient to walk, if the patient is having a scissoring or a hemiplegic gait, you know it is upper motor neuron. But if the patient is having a high steppage gait, then you have an idea that it is a lower motor neuron. Am I understood?
Yes, sir.
All right. So that is just what I wanted to ask you. And yeah. So you check the gait, then you check the tone. In tone, the tone would be increased in upper motor neuron. But when the tone is increased, you need to specify whether it is a rigidity type of pattern or a spastic pattern. So in the upper motor neuron, it is a spastic pattern. Versus in
Yes, sir.
lower motor neuron, you would expect the tone would be reduced.
Yes.
Now, power you would expect to be reduced in both of the patterns, upper and lower motor neuron. But in an upper motor neuron, the power is reduced in a pyramidal weakness type of pattern, which means in upper limb, the extensors are
Flexor, sir.
weaker than the flexors. And in the lower
Yes, sir.
limb, the flexors are weaker than the extensors. So this pattern is called pyramidal pattern, which will be there in the upper motor neuron, but it will not be there in the lower motor neuron. And the reflexes, you all know, they are supposed to be exaggerated. The plantar is supposed to be upgoing. The clonus is supposed to be present in upper motor neuron. And the reflexes are supposed to be hyporeflexia. The plantar is supposed to be downgoing or absent. And the clonus is supposed to be absent in a lower motor neuron. This is basics, right?
Yes, sir.
So I will move forward. And this is the only prerequisite that I expect from each one of you to know, which I'll be discussing as well again. That you know the basics of spinal cord tracts. So the first one that you need to know is the motor tract, which is corticospinal tract. It begins from the brain, it crosses at the level of medulla, and then it goes down in this particular form. I just want to know if I can just let me know if a pointer is visible. Is this visible? Neha ma'am, is this visible?
Yes.
Yes,
Okay.
very well.
Yes.
So when we talk about the motor tracts, the corticospinal tract, they arise from the brain, then they cross at the level of brainstem, and then they descend. And then they supply their lower motor neuron. When we talk about the sensory tracts, the spinothalamic tract, they actually cross at the level of spinal cord only, and then they ascend, which carry the pain and temperature pathway. And the dorsal column, which carry the fine touch, proprioception sensations, they are ipsilateral sensations which ascend from the same side and then they cross at the level of brainstem. This is also basics. This is also something that I hope most people already knew. I just wanted to share this once. Now, yeah, okay. So what actually comprises in a lower motor neuron? So in the corticospinal tract, when I mentioned that the fiber is descending from the brain, crosses at the level of medulla, and then it goes to the spinal cord, it actually terminates at the anterior horn cell. The anterior horn cell is a part of lower motor neuron. All right. And from anterior horn cell, another fiber goes out, which is the entire lower motor neuron. It has 7 components that I have written in the screen. The first one is the anterior horn cell. Then you can see from this diagram that there is a motor root and a sensory root. So from the motor root, there is a root which forms a plexus and there is a ganglion there. And then you see a nerve which goes on till the neuromuscular junction which supplies the muscle. Why are we reading this? Because we get different disorders in neurology and we want to localize the disorders to each particular anatomical tract. Which disorder is there in the anterior horn cell? It is post-poliomyelitis or a motor neuron disease like ALS. For roots, we have radiculopathies. For plexus, we have plexopathies, similarly ganglionopathies, then peripheral neuropathy, we read in nerve. For neuromuscular junction, we have myasthenia gravis, and for muscles, we have myopathies. So now you know all the disorders from the element and how will you localize them. The approach we are going to read now. At till this point, it is clear. Just give me a thumbs up. I also need some validation from you guys that I'm going. Is it okay till now? All right. So from cases point of view, this plexus and ganglion are not very important. We don't often see the cases. We usually see anterior horn cell cases like post-polio and motor neuron disease. Radiculopathies, we usually keep as the differential diagnosis in some of the cases. Neuropathies are the most important one. More often than not, you will only find these cases. Then myasthenia gravis is usually a case in a long clinical consultation, could be a case in neurology session as well, and myopathies are also common cases. So why are we reading radiculopathies? So when you see a case of foot drop, the differentials that you give are common peroneal nerve palsy and a L5 radiculopathy. Why this happens? So the L5 root, which comes from the plexus of the lower limb, the L5 root, when it is involved, its dermatome and myotome will be affected, which means the muscles that it supplies and the sensory part from which it takes the sensation, they will be affected. So that is why in foot drop, apart from common peroneal nerve palsy, the second differential that you give is the L5 radiculopathy. Similarly for wrist drop, since C7 is the one which supplies the radial nerve, its involvement will lead to wrist drop. I hope you are able to follow me till now.
Yes, sir.
Yes.
Yes, sir.
All right. So now the most important topic, neuropathy. We'll give it good time and I want everyone to take away this topic from today's class. So neuropathy, I hope you're able to follow by anatomy what we have done, that we started from anterior horn cell, radiculopathy, we skipped plexopathy and gangliopathy for now. And now we are at neuropathy. Anterior horn cell we'll discuss later. So neuropathy means peripheral nerves are involved. Now we can classify the peripheral nerve disorders in various ways. You can classify it as a mononeuropathy versus polyneuropathy. You can classify by the based on the size of the fiber, like large fiber neuropathy versus a small fiber neuropathy. Or you can classify it as an axonal versus demyelinating neuropathy. Why this is important? You can go on and learn all the classification, the Erlanger and Gassner, but if I want you to remember one particular point, then just let me find the pointer again. Yeah, is it visible? The pointer? Quick yes or no?
Yes.
All right. So this large fiber, the important fibers that you need to remember from the large fiber are the motor fibers, which are the corticospinal tracts, and this touch, vibration, proprioception, which means the dorsal columns. Similarly, for the small fibers, you need to remember that it carries the pain and temperature sensations and the autonomic fiber. All right, so I've put it here again that large fiber means corticospinal tracts and dorsal column, and small fiber is spinothalamic tract, which means pain and temperature. So when we read about large and small fibers, large fiber, I told you it was dorsal column and corticospinal tract. So when dorsal column is affected, the patient is having a tingling and paresthesia sensation. The patient will be having some numbness and sensory ataxia. Because the corticospinal tract is affected, the patient will be having a motor weakness, which will be a proximal plus distal pattern. All right. The common example is vitamin B12 deficiency and Friedreich's ataxia. Just read what I'm telling right now, it will make sense. Versus in small fiber, we talked that pain touch temperature will be affected. And it is a length dependent pattern. So You see this glove and stocking involvement, that pain touch temperature is affected in a glove and stocking pattern. That is a small fiber neuropathy, and the important cause is diabetes. You can also understand this in a demyelinating and axonal pattern, which is very similar to large and small fiber only. You will find only very subtle differences between the two. The demyelinating pattern is also involving the dorsal column and the corticospinal tract. See, large fiber, symmetrical, proximal distal. Sensory means posterior column is affected. Loss of reflexes. So can you connect this all? If a patient is coming to you with tingling and numbness of lower limb and a proximal plus distal weakness, does this points towards AIDP to you or not? Just let me know yes or no.
The AIDP pure motor, sir.
See, AIDP or CIDP can have a sensory motor presentation. It is a polyradicular neuropathy. So it can have the GBS cases that you see in your wards. Do they don't have any sensory symptoms?
They have, sir, but
They have now.
yeah.
And the reason for that is posterior column.
Okay.
Yeah. And similarly for this axonal pattern, it is a small fiber length dependent stocking and glove pattern. And the common example is diabetes. I hope I'm not giving too much information and it is making sense to you. You are able to build the information that what we are talking right now is neuropathy. And in neuropathy, we are discussing about either large versus small fiber or a demyelinating and axonal. In either of the cases, in one side, we are seeing the dorsal column and corticospinal tracts, and in the other side, we are seeing the spinothalamic tracts. All right. So what do I have? Yeah. So that was about neuropathy. But when you see a patient of neuropathy, in PACES, you need to give the examples of pure sensory, pure motor, and sensory motor. So one of you, can you unmute yourself and tell me the examples of pure sensory patterns of neuropathy? Dr. Raghu, can you tell me the examples of sensory
What do you
neuropathy?
want, sir? Examples of sensory neuropathy?
Yeah.
So diabetes, alcohol,
Yes.
hypothyroidism, uremia, vasculitis,
Perfect. Vitamin B12
and
deficiency.
vitamin B12
Yeah.
deficiency, paraneoplastics.
Perfect. And for pure motor?
Pure motor is basically lead porphyria, drugs such as dapsone,
Perfect.
CIDP, AIDP.
So CIDP, ADP are motor predominant. It is perfectly
Yes.
fine that you are giving this example here. So when I said motor, I shouldn't have said pure motor. I wanted to say motor predominant.
Yes,
So
sir.
when you said that lead, dapsone, these are pure motor.
Porphyria.
Other than that, AIDP, CIDP, these are motor predominant.
Yes, sir.
That is why earlier also I was telling you that it has sensory motor pattern involvement. It is motor predominant. And when I ask you for a sensory motor neuropathy, then you can give all the examples of sensory along with hereditary sensory motor neuropathy.
Yes, sir. Yes, sir.
So till this point, if any of you have any question, if you want me to repeat anything, please let me know, because this was the most important takeaway from today's class, that you understand what are the components of a low motor neuron, and in those, the most important one is neuropathy. So do you understand right now the difference between a large fiber and small fiber, or a demyelinating and axonal pattern? And do you now know the examples of this sensory and motor neuropathy?
Sir, yes. Can I ask you?
Please.
A patient given with both lower limbs, there are weakness in both lower limbs and no sensory involvement. Can we say acute presentation? Can we say GBS as one of the DDs?
So you're telling me, can we discuss this case when we do the pure motor patterns after that?
Okay, sir. Yes, sir.
Because I wanted to do the sensory motor patterns first and then the motor patterns. So let's
Okay, sir.
do the motor patterns and then we'll see this case.
Doctor, I have questions.
Yeah, please.
How can differentiation between the peripheral neuropathy and coda equina?
Oh, all right. So Cauda equina and conus medullaris and peripheral neuropathy. So chorda equina, you should be having any, based on the examination of the lower limb, I don't think it is possible without asking the bladder and bowel symptoms. And then when you check the perianal sensations and the knee jerks and the ankle jerks, these are the things that we need to check in the chorda equina also.
Yes, and also presented with lower motor neuron pattern weakness, yes?
It is a mix of upper and lower motor.
Mix upper.
Predominantly, it is chorda equina is predominantly lower motor neuron only, and conus medullaris is upper motor neuron. But I think yes, it is slightly. I'll have to just check again.
Yes,
Sir, I
regarding the
think
sensation
conus
is normal
medullaris
except
last class, sir. Madam told us that it's a combination of human element because
Correct.
at the end of the cord, there are also nerve fibers which are originating from that, which is phylum terminale.
Yes, that is correct.
So both are affected. So you'll have presentation like human plus element, similar to like what we see in Friedreich's ataxia or a combination of cervical myelopathy with peripheral neuropathy. Human sign that's ankle absence and plantar extensors, like that,
All
sir.
right.
She told.
That is
Conus
correct.
medullaris.
Yeah,
Chorda equina purely element with sphincter disturbance, definitely.
right. Because the nerves are affected. Chorda equina means that from the spinal cord, when the nerves are going, the sacral and the lumbar nerves, both are being affected. That is why it is a low motor neuron.
yes, but bilateral or unilateral?
Should be
Yeah, that was the
unilateral.
discussion also, Dr. Neha, last time, sir.
Chorda equina should be unilateral, no? It is asymmetric.
And peripheral neuropathies are always bilateral. That is
Bilateral.
a key difference.
Normal sensation except into the private area, yes?
Yes.
Okay.
You
All right.
have to look for the bladder involvement, like Sir told, and there will be patchy sensory disturbance, whereas in peripheral neuropathy, it is glove and stocking, what you are going to find. Am I right?
Yes. So
Right.
let's just move from this sensory motor pattern to the pure motor patterns. Now, please understand that if you are examining a patient and you are seeing only motor symptoms and it is a low motor pattern, then these are the three possibilities: anterior horn cell, neuromuscular junction, and muscles. And it is very easy to differentiate. When you see anterior horn cell, usually only one of the limb is involved. So when you see that a patient is lying down, his left limb is looking shorter than the right limb, it seems very wasted and atrophied, and no reflexes you can appreciate. And you might be able to see some fasciculations also. So you know that anterior horn cell is affected. And the differentials for that could be post-poliomyelitis and motor neuron disease. Second possibility for a pure motor pattern is a neuromuscular junction, that is myasthenia gravis. The easiest point to demonstrate, or you can demonstrate in the history particularly, is the fatigability. That is the diurnal variation. That is the patient having more symptoms in the evening than the morning. Second thing, you can appreciate ptosis. So when you see a patient of myasthenia in the neurology station, the first thing that you want to check is for the ptosis. You ask the patient to look up and count to 20. So in that, you're checking for the ptosis and you're checking for the voice hypotonia. When the patient is speaking for a long duration of time, the voice also reduces. And then weakness is there. If you ask the patient to lift their hand after a lot of movement, then their weakness gets exacerbated as well. So that is the concept of fatigability in a neuromuscular junction disorder, which is myasthenia gravis. And the last pattern is myopathy. Myopathy means it is a bilateral, symmetric, proximal weakness. These examples include polymyositis, dermatomyositis. It could include hypokalemic periodic paralysis. There are multiple examples in myopathies, limb girdle atrophy, and Duchenne's. All these come under myopathies. So this is how you differentiate a pure motor pattern dividing these into anterior horn cell, neuromuscular junction, and myopathy. I hope I'm able to deliver. Are you able to understand? Any question in
Yes.
this particular slide? If not, then I want to practice a case with someone. Can someone volunteer?
Yes, sir. I'm there.
So, Dr. Raghu, the case that I wanted to discuss with you, I began in the beginning of the session only, that you entered the neurology station, and the command given to you was the patient is having difficulty in walking, examine the lower limb. So, please begin. You check for the surrounding, and I don't
Check
think you
for the
found any
general
transmissive.
inspection,
Yeah,
wasting, muscle wasting, any involuntary movements, the
no obvious
deformities or
wasting, no involuntary movements,
scars, deformities. Okay.
not as such.
I ask the patient to walk, sir.
Right. So with the eyes open, the patient seems to be walking in a normal pattern only.
Okay. Eyes looking down.
Yes.
Okay. And when eyes are closed, in a standing Romberg signs are then?
So I'll be just correcting in between also that
Yeah.
once the patient is walking normally, then the second thing that you ask the patient is to do tandem walking.
Okay.
That is foot to foot walking. And actually, even before that, you ask the patient to stand still. If the patient is able to maintain the balance, then you ask him to close your eyes, close his eyes.
Okay.
So,
Okay.
do you understand the concept of sensory ataxia?
Yes, sir.
I mean
By
to ask
closing the eyes,
is,
we are removing the sensory input.
the Romberg's test that we do, that close your eyes and maintain your balance. We do that to check for sensory ataxia and not cerebellar ataxia.
Correct.
If a patient's cerebellum is affected, then it doesn't matter his eyes are closed or not. He will have imbalance. But if he is having peripheral neuropathy and he is having sensory ataxia, then the imbalance will be there only when his eyes are closed. The imbalance will go away the moment he opens his eyes. Are you able to understand this?
Yes.
All right. So
Mm.
that is why we do Rombergs. We ask the patient to stand. If the patient is able to maintain the balance and he seems to be looking downwards, then you ask him to close his eyes. If then he loses his balance, that means the patient was having sensory ataxia. All right. And then you ask the
Okay.
patient to walk and then do tandem walking. So this is how you check for the gait. In this whole scenario, in this particular patient, the patient seems to be having some sensory ataxia. All right. Now, can you go further and do other tests?
Yes, sir. Once we made the patient to walk tandem gait, then Romberg's test.
Yeah. So the patient seems to be having some sensory ataxia.
Okay.
What next?
Then probably examine for tone, power, reflexes regularly, sir.
Yes.
All the
Please
other
carry on. You check for tone. How do you check for tone?
Once again, rolling the limbs, the lower limbs, and look for any. How is the tone? Check the tone by rolling the limbs, lower limbs,
All right.
one by
So
one.
tone seems to be normal. There is not much affected. So I mean, it is not exaggerated for sure, and it is not like a floppy limb also. What
Okay,
next?
sir. The power of the lower limbs.
All right. Power also, I think it is like 4 by 5 in the both limbs. Not much
4
affected.
by 5.
Yeah.
Then check for reflexes.
So reflexes, see the problem with reflexes is if I go by a bookish case, I can tell you that the knee reflex was normal, the ankle reflex was absent, and the plantar reflex was normal. But in real life, when you go and practice patients, you don't get these findings. All right. So right now, for this particular case, I'm telling you that the ankle reflex is absent. What next?
Ankle reflex absent and plantars.
Plantars are normal. I
Ankle
mean,
reflex.
not always will you find the planters are upgoing. That is why I'm telling you they are normal. Sometimes we are not able to appreciate. Our technique is not right or the patient is fatigued. So let's say that the planters are normal or they might be extensor only. What next?
Okay. Then check for cerebral signs, sir. Coordination
How would you check it?
by bringing the heel to toe, sir. Heel, shin to toe, shin to foot. We have to bring down in arc position, shape like.
It seems to be okay.
Okay.
Yeah.
And then check for vibration sense and dorsal column check, sir, with the toes
How would you check
asking
it?
for flexion or extension of the toe we do and make the patient to say whether it is up or down going, up going or down
How
going.
much
The
degree of movement do you do in that particular movement?
how much degree you bend the finger toe, you mean?
Yeah, the great toe that you move, how much degrees do you move?
Maybe 30 to 45 degrees, sir.
No, you only move 5 to 10 degrees because after 30 degrees, it is very evident. Even if the dorsal column will be affected, some of even if the dorsal column is affected, everybody will be able to appreciate. So you move very less. You move only 5 to 15 degrees.
Okay,
All
sir.
right. So when you
Okay.
do that in this particular patient, the patient is not able to appreciate. What
Little
next?
bit go up, sir. Maybe if the toe is not appreciating, you have to climb up to the ankle level.
Understood. What next?
So at ankle level is as got.
Ankle level also he might be able to appreciate, I think.
Okay, then we'll leave it, sir. Then vibration can be assessed in this patient
I
with the
want you
tuning
to
fork.
check the pinprick sensation now. Please check.
Yes, a pinprick
How
from the
would you
foot
check it?
and from top to below, sir.
How would you check it? I mean,
At
just
the inner aspect of the anterior aspect of thigh, both
okay.
sides,
Okay.
asking for the prick is very
It is
sharp or
there.
blunt.
It is there.
Ankle is there. I mean, then below we have to come at the level of above knee on both sides.
So you would go in a dermatome pattern L1,
Yes, sir.
L2, L3,
L2.
L4, L5, S1, and S2, right?
Yes, sir.
And you would check in the both limbs simultaneously, left limb, right limb,
Yes,
left limb, right
yes, sir.
limb, right?
Yes, sir.
So in the thigh region, it is there. In the shin region, it is there. But in the foot, it is absent.
Okay, sir.
Now, what would you do?
Pinprick and temperature, I don't think we check, no, sir. Pinprick is
I'm
equal to
telling you,
temperature.
in the foot, the sensations are absent.
Yeah.
Now, what would you do? So, I'll tell you that if this is the lower limb and the patient is able to appreciate the sensation here, but not here, am I visible to everyone?
Yeah, yes, yes.
So, what you would do is you would start picking these patients like in this pattern. You would go millimeter or centimeter by centimeter and try to know the level at which the sensation goes away.
With the
So
pinprick.
maybe if this is the foot of the patient, they will not feel the sensation up to this point. And after this, they will be able to differentiate. This
Okay, sir.
means that dermatome is not affected. It is the peripheral neuropathy because of which the sensory loss is there. Are you able to follow this?
Yeah.
This was the point that I wanted to bring. That is why I did the whole case scenario. That in this particular type of case, you need to check the gait, then you need to check the tone, you need to check the reflexes. But with the reflexes, please take it with a pinch of salt. In so many patients, the ankle reflex would be there, but you wouldn't be able to appreciate it. This happens, agreed or not? Many a times it happened with me earlier that I was keep on hammering the ankle, but it was my fault that I was not able to appreciate the ankle reflex. So that is something that you need to practice a lot. And the last thing with sensory is that when you find that the sensory loss is there in the foot, you need to go by inch and you need to check it and find the sensory level. So all in all,
Can I ask the
what,
question?
sorry?
Question, sir.
Yeah, please.
When you said the ankle reflexes aren't elicited,
Yeah,
can we do reinforcement techniques?
of course, you have to.
Can you just clarify on the reinforcement technique, sir? What it really?
So when you're checking the lower limb and you want to do reinforcement, you'll ask the patient to hold their hands like this and stretch it. Is this what you're asking me?
Yes, sir. Yes, sir. True.
That is what you need to do. And when you are
And
doing
once,
the upper limbs, then you ask the patient to clench their teeth.
okay, sir.
All right. So
So
what
what
do
does that
you
indicate, sir? Suppose you're doing reinforcement and the reflexes are exaggerated in the lower limbs. What does that
exaggerated?
really mean? I
From
mean,
being
whatever they are
absent to exaggerated.
by reinforcement method, sir.
After reinforcement, you are telling
Yeah.
me that before reinforcement, the reflexes were absent. And then
Yes.
after this, the reflexes are exaggerated.
It is seen, maybe it is elicited, I can say.
If it is elicited right now, so that means the
Yeah.
patient is fatigued. So many people have come and practiced on that, or maybe the nerves were not in that. Reinforcement is a normal phenomena. If you're not able to elicit and you're doing reinforcement and then the reflex is there, it is a normal thing. It doesn't have to mean
So
anything.
okay, so then we can say the reflexes are normal.
Yeah, if you are able to elicit after reinforcement, then it is a normal reflex only.
Got it, sir. This was the
Yeah.
clarity I want.
Yeah.
Thank
So now, Dr. Raghu, what do you make of this case? Can you
you. Okay.
present this case right now to me in a minute?
Yes, sir. This gentleman has got sensory ataxia on gait with tandem gait, and tandem gait was normal, and with Romberg's was positive. Along with it, patient had a mild reduction in power and reflexes on the lower limbs, and diminished proprioception up to ankle level, and also pinprick sensation was also reduced, was also absent till mid shin. With these findings, the patient has most probably a sensory motor neuropathy, sir.
What would be your differentials?
I would put on the top of the differentials as diabetes mellitus, alcohol, and vasculitis, hypothyroidism, uremia, paraneoplastic vasculitis, autoimmune disorders.
Right. So you're telling me the differentials of the causes of peripheral neuropathy.
Yes.
And what other causes could be there? I'll ask you a question and I know you know the answer. So when I ask you a question that what are the differentials when you see absent ankle with extensor plantar? I know in this
Yes, sir.
particular case, I
That's a
said the plantar was normal. It could have been extensor also. So when I ask you that what are the differentials for
subacute
absent
combined
ankle and
degeneration of
extensor
the cord,
plantar?
subacute combined degeneration of the cord,
Yes. Number two,
MND, Friedreich's ataxia,
Friedreich's ataxia. Just
combination
you
of
can stop there.
yes,
So that is what I wanted to tell you that these cases can come like this pattern only, and not always you will find the ankle reflex absent, not always you will find the extensor plantar. But you need to know a background that if a patient is having with weakness in walking, difficulty in walking, and you're able to demonstrate the sensory ataxia, and you're able to differentiate a absent ankle or an extensor plantar, and you're able to differentiate a sensory level which was there till the level of ankle. All this points you that you are going towards a case of peripheral neuropathy, which can have a differentials of subacute combined degeneration or a Friedreich's ataxia. You're able to understand this?
yes, sir.
So after this, when the examiner will ask you investigations and management, you will be able to tell that you will go for the complete blood count and everything. Yes or
Yes.
no?
Yes, sir. You said there is patient is giving absence ankle and extensor plantar or normal, whatever you said.
Yeah.
But the patient has also affected spinothalamic tracts also, no, apart from dorsal column in this
How?
pain.
Yes.
Is it pinprick?
Yes. So that is what I want to tell you that those patterns that are affected, that is because of peripheral neuropathy. So the pain can be affected This is a very good question, and this is something that even I understood after a lot of time. Everyone, please pay attention. This was an excellent question that you need to understand that pain can be affected either because of involvement of spinothalamic tract, but it can be also affected because of peripheral neuropathy. If small fibers are affected in peripheral neuropathy, then also pain can be affected. So when in this lower limb, in only this particular ankle, the pain was not felt, it was not because of spinothalamic tract. It was because of peripheral neuropathy. That is why we discussed this whole topic, and that is how we came to the differentials of subacute combined degeneration and Friedreich's ataxia. Did I answer you correctly?
Yes, sir.
Yeah. Any other doubt? So that is all that I was prepared for today's class. I wanted you to have an idea about the lower motor neuron. I'll just recapitulate everything. So we began from the 7 components of lower motor neuron, which includes an anterior horn cell, which is asymmetric, wasting more than weakness, and fasciculations will be there. Then radiculopathy will have a dermatome and myotome involvement. Plexopathy, gangliopathy we skipped. Neuropathy, now I hope you understand it can be differentiated by large fiber, small fiber, or demyelinating and axonal. Now you know the sensory causes, the motor causes, and the sensory motor causes. And you know about the neuromuscular junction, the myasthenia gravis, and now you know about the myopathy also. And then we discussed a case in which the patient was having sensory ataxia, a sensory level till the ankles, and absent ankle extensor plantar. This is a very common case that you will see in PACES exam. So if everything was understood, we can stop the class or we can have any
So
question that
one
you want.
question. In the
Yes.
same scenario, can we fit the diagnosis for HMSN?
Can you please pardon?
You said plantars were flexors or normal, which you said, maybe extensors. And since there is dorsal column and there's pain prick affected, there's some slightly motor deficits is there, which you said, and the sensations are lost to some modalities. So can we say HMSN as a differential diagnosis here?
Let me think over. HSMN is a motor neuropathy, sensory motor neuropathy. So HSMN you can keep as a third or fourth differential, but not as a first or second differential. The entire game in the PACES is giving the right order of differentials. Why HSMN will not be the first or the second differential is because this sensory involvement will not be in this particular pattern, that only the ankle is affected. But yes, you can keep it as a differential. That I agree. But not in the first or the second differential. I hope you understand why.
Yes, yes.
Any other question?
Yes, I have one question, sir.
Please.
Touch. Is it mediated by dorsal column or the spinothalamic tract?
It is actually done by both. It is just about crude touch or fine touch. If I answer your question more in detail, the spinothalamic tract is the more primitive tract. And the dorsal column were evolved much later in the evolution. So the spinothalamic tract carry the crude touch. But if you're talking about the cotton touch, fine touch, that you are able to discriminate between two close points, those kind of sensations, the proprioception, that is joint position or the vibration, that is something that is taken up by the dorsal column. So that is why when you check, when you have only 5 to 6 minutes in the exam and you want to check and differentiate between these two, so you go for pain, that is pinprick sensation, and the soft touch. And for dorsal column, what you check is the proprioception by doing this finger flexion and extension. Touch is
Crude
not
touch,
something that you will use to differentiate between these two in those 5 minutes.
crude touch is similar to pressure, but that is carried by dorsal column, isn't it?
No. So touch and pressure are two different things. And we can have a discussion on this, that how much touch would be a pressure, but I don't think it would make any clinical sense right now. I think to differentiate between these two, it's better if we use proprioception and pain sensation.
Okay.
That way, we are very clear that pain is 100%. We know that it is taken by spinothalamic only. And the vibration and proprioception, it is for sure taken up by the dorsal column only.
Okay.
Right? Any other question? All right. So I think we are done with today's class. We can end the session.
Hello.
Any question?
One small
So,
request, sir. Hello?
Can we give a differential diagnosis for the case like abscess engaged and extensor plantar response? In this case, like we can give like spinal cord injury plus peripheral neuropathy, like this combination.
I'm so sorry, I was unable to hear you. Can you please pardon?
Can we get the differential diagnosis for the like in the abscess engaged and extensor plantar response? Can we give like the like spinal cord injury and the patient have previous history of the peripheral neuropathy like diabetes, like miscombination? Can we give these differential diagnosis?
So you're asking me for absent ankle and extensor plantar, the differentials for that.
Yes.
So for absent ankle and extensor plantar, the differentials are very easy. You need to understand that it is a combined upper and lower motor neuron, right? So the
Yeah.
differentials could include a stroke with peripheral neuropathy. It could include a motor neuron disease. It could include a subacute combined degeneration, Friedreich's ataxia. These are the differentials for that.
Okay.
I'm not sure if I answered your question.
Hello, sir.
Yes. Okay. Thank you.
All right.
Sir, can you just go to that first slide which you have shown 6 scenarios,
Yes.
and can you just conclude this session by just talking 3 differential diagnoses for each scenario?
Yes. Now please figure out. This is something for everyone. Now can you identify the patterns? So symmetrical distal loss with or without weakness. So does it sounds like a small fiber neuropathy like in a case of diabetes or not? So in diabetes,
Peripheral neuropathy, sir?
yes, it is a peripheral neuropathy, but we are going one step beyond and we are dealing which kind of peripheral neuropathy this is. So in diabetes, we read about stocking and glove pattern. So this is what we talk about there. It is a symmetrical distal sensory loss. Weakness could be there, could not be there. Understood?
Got it, sir.
Yeah. Now the second scenario, symmetrical sensory loss with distal areflexia and UMN feature. Symmetrical sensory loss with absent ankle reflex, which is
human
distal
element,
areflexia, and UMN feature means extensor plantar. What is this?
Subacute
Second
and
MND
combined degeneration.
Very
attacks.
good. Excellent.
Friedreich's
Third
ataxia.
scenario, very good, excellent. Third scenario is symmetrical proximal and distal weakness with sensory loss. So proximal
Radiculopathies.
and distal weakness with sensory loss, again it is peripheral neuropathy only, but now this time it is a large fiber neuropathy.
Radiculopathies.
I'll just read this again. If a patient is having a tingling sensation in lower limb with a proximal and distal weakness and it is ascending upwards, it is a bilaterally symmetrical. I'm describing a case of AIDP or a CIDP. So it is a large fiber or a demyelinating peripheral neuropathy. I hope you're able to understand. The fourth scenario is asymmetrical distal weakness without sensory loss. So this is,
Radiculopathies.
sorry?
Radiculopathies, sir.
Radiculopathy will have a sensory loss. Why? Because if a radical like C5 is involved, C7 is involved, in which there is stress drop, then the sensations of C7 will be affected. If it is an asymmetric weakness without sensory loss, this means it is a pure motor, which means anterior console is affected. It could be a case of post poliomyelitis or a
MND.
MND.
Okay, sir.
All right. And the last one is if a patient is having bilateral symmetric proximal weakness without any sensory loss, then it is
Proximal myopathy.
Myopathy.
very good.
Myopathy.
Perfect. Perfect. So I think we have
So
done a
small
good job.
request, sir.
Sorry.
Request from your side. Last time, day first day, I think Dr. Neha gave the speech on part 1 neurology, if I'm right.
Can you please pardon?
Dr. Neha by name, who gave the presentation part 1 nephrology, neurology station, part 1 she gave. She spoke on
Yeah.
the localization of the lesion, whether it is cortex, subcortical, or this. You have the recorded one. Can you post it, sir, please, so that we can go through?
I'll ask her.
Thank you so much.
All right.
The last pattern be motor neuron disease.
The last one. Dr. Fikri, are you asking about the last case scenario? Symmetrical weakness?
Yes, no. The patterns, yes.
So motor neuron disease is supposed to be asymmetric. That is how you differentiate that if the patient is having symmetric and proximal weakness, then it goes towards myopathy. And if it is asymmetric distal weakness, then it goes towards the MND. And of course, in a motor neuron disease, you would find fasciculations. More atrophy will be there in MND, but more weakness will be there in a myopathy. So this is just one line that I wrote, but when you will see a patient, you will know that.
All right.
All right.
Thanks.
All right. So thank you so much for joining this session and
Thank you. Thank you.
have a good night.